The deep dive is back, and today we are on the hunt for the so-called magic bullet.
A fascinating topic.
We're diving into the really dense but critical world of anti-infective agents, and all our insights today are coming from Chapter 8 of Focus on Nursing Pharmacology, 8th edition.
A great source.
And our mission here isn't just to, list off terms. It's to understand this incredible high-stakes tightrope walk.
How to kill the pathogen
without poisoning the patient. And, maybe even more importantly, how we keep our best tools from becoming totally obsolete. We're going to unpack the core concepts, the mechanisms of attack, safety protocols, and the huge crisis of microbial resistance.
It's a real challenge. And to really get it, you almost have to look back a bit.
Oh.
I mean, anti-infective therapy isn't new. It has roots in ancient practices, like the Chinese using moldy curds on skin infections.
Wow.
But the scientific search really kicked off in the 1920s with a man named Paul Ehrlich. He was searching for his magic bullet for a chemical with what he called selective toxicity.
Selective toxicity. That feels like the key phrase for this whole deep dive.
It is. It's the cornerstone. It's the ability of a drug to affect an enzyme system or some component that the infecting organism uses.
But not one that our own human cells use.
Precisely. That is the ideal goal. But here's the really interesting part.
Go on.
No anti-infective drug has ever achieved total selective toxicity. Not one.
And that gap, that failure to be perfectly selective,
is exactly why we see adverse effects in the host. It's unavoidable.
that sets the stage perfectly.
Yeah.
So let's start with the basics. The drug's actions, we classify them by what they do to the pathogen, right?
We do. The first is bactericidal.
Which means it causes the death of the bacteria, it interferes with the cell membrane or its integrity.
Yep. It's the outright killer.
And the other.
Is bacteriostatic. This one is different. It just prevents the bacteria from replicating, from reproducing.
So it basically stuns them.
It stuns them, and that gives the host's own immune system time to catch up and clear the infection. It's important to know, too, that many drugs can do both. It just depends on the dose.
Okay, so beyond what it does, there's the question of its range. The drug's spectrum.
Right. Is it a sniper rifle or a shotgun?
I like that analogy. So a sniper rifle would be.
Narrow spectrum. Effective against only a very selective, very specific group of bacteria. It might target a unique metabolic pathway only they have.
And the shotgun.
That's your broad spectrum. It hits a wide range of bacteria because it targets something more common, like a biochemical reaction lots of different bugs use.
Very useful when you don't know the exact invader, I'd imagine.
Extremely. But their overuse is a huge part of why we're in this mess with resistance.
And you mentioned not knowing the enemy. To avoid that, we have some key clinical tools, right? Before treatment.
Oh, absolutely. Guesswork is not an option if you can avoid it. We rely on culture and sensitivity testing.
Culture. That's taking a sample, urine, sputum, whatever it is.
And growing the organism in a lab, it lets you identify the exact species you're dealing with.
And once you know what it is.
That's when sensitivity testing takes over. You test that specific culture against a whole panel of different drugs to see which ones actually work against that specific strain.
That seems absolutely vital.
It is, especially with bugs that are notorious for developing resistance.
Now, we usually think of these drugs as treatment, but they're also used defensively, as prophylaxis.
Exactly. Treatment to prevent an infection before it can even start.
So for you listening, this isn't just theory. This can be the difference between, say, an amazing vacation and a life-threatening illness.
Absolutely. The classic examples are taking anti-malarials before traveling or giving antibiotics to a high-risk cardiac patient, maybe someone with an artificial heart valve, before they have major dental work done.
To prevent bacterial endocarditis.
Precisely.
Okay, let's get into the fight itself. The textbook lays out 5 major ways these drugs attack.
The goal is always surgical precision.
Right. So, first up, they interfere with cell wall biosynthesis. This works so well because bacterial cell walls are fundamentally different from our cells. We don't have them.
The penicillins are a classic example of this mechanism.
And the book highlights a specific drug here, bacitracin.
Right. Bacitracin is a great case study. It also targets the cell wall, specifically in staph bacteria, but because of its toxicity risks.
Like kidney damage, nephrotoxicity.
Exactly. That and also superinfections. Because of those risks, its use is now heavily restricted. You mainly see it topically or for very specific infant respiratory or eye infections.
So that control is a direct response
Yeah.
to its toxicity and the resistance problem.
It is.
Okay, mechanism number 2 is inhibition of protein synthesis. synthesis.
Proteins are essential for a cell to, maintain itself and divide. We can target this because bacterial ribosomes, the little protein factories, are different from human ribosomes.
And drugs that use this method.
Aminoglycosides like gentamicin and also the macrolides, they exploit that structural difference.
Third, some drugs go right for the genetic code, interfering with DNA synthesis.
Mess with the DNA and you get cell death pretty quickly. That's the method used by fluoroquinolones.
Fourth is basically starving the pathogen.
Blocking the use of essential nutrients. If the bug can't process the chemicals it needs, it can't grow or divide. Simple as that. The sulfonamides use this tactic.
And the fifth and final mechanism.
Altering cell membrane permeability. These drugs just poke holes, essentially, in the outer membrane of the pathogen.
Causing everything inside to leak out.
Right. The cell collapses and dies.
This all sounds like a pretty foolproof arsenal. Which brings up the big question. Why do these drugs stop working?
Adaptation. In a word, resistance. The ability of a pathogen to change over time so the drug no longer affects it.
And this can be, what, two different types?
Broadly, yes. It can be natural or intrinsic, which just means the drug never worked on that bug to begin with. It lacked the target. Or it can be acquired, which is the clinical nightmare. That's where the organism actually changes after being exposed to the drug.
So how do they do it? What are their tricks?
They have four main strategies. First, and this is a big one, they can start producing an enzyme that directly inactivates the drug.
Wait, like penicillinase? That enzyme that breaks down penicillin? Is that why that whole class of antibiotics is used so much less now?
Precisely. That is the classic example of enzymatic resistance winning.
Okay, what's the second strategy?
They can change their cellular permeability, literally pump the drug out or just refuse to let it in.
Clever. And the third?
They can alter the binding sites inside, on their ribosomes, for instance, so the drug molecule just doesn't fit anymore. It can't lock on.
And the last one?
They can start producing a chemical antagonist that just cancels out what the drug is trying to do.
This fight against resistance is why we have these drugs of last resort, isn't it? Which brings us to a huge one, vancomycin.
Vancomycin is a fascinating story. It's a lipoglycopeptide. It interferes with cell wall synthesis, but it is reserved only for life-threatening infections or for patients with severe penicillin allergies.
And the reason it's reserved tells you everything.
It does. It's highly toxic. We're talking risk of renal failure, ototoxicity, that's damage to the 8th cranial nerve, causing hearing loss, and some really severe adverse effects.
Like the one everyone's heard of, Red Man syndrome.
Exactly. A dramatic, rapid reaction, severe hypotension, fever, chills, and this intense flushing and redness all over the neck and back. It's a powerful weapon that has to be handled with extreme care.
So given this massive threat, what can we do? The text lays out 3 critical ways to prevent resistance.
First, limit the use of antibiotics to specific, sensitive pathogens. And this is huge. Do not use them for viruses like the common cold. It does nothing.
Second, dosing is critical.
It has to be high enough and the duration has to be long enough to kill every last microbe. This means taking the drug around the clock to maintain constant therapeutic levels. No dips.
And the third way is all about the patient.
Patient adherence. This is box 8.4 in the text. You have to teach them emphatically to take the full course of the drug, even when they start feeling better.
And never, ever save pills for later.
Never. But clinically, how hard is that to enforce? Adults come in demanding a quick fix for everything.
It's incredibly difficult. And that demand for a quick cure is listed as a major issue in the lifespan considerations for adults. But let's zoom out a bit. How does this tie into the body's own defenses?
Well, the goal of the drug isn't actually to kill every single pathogen.
It's not.
No. The goal is simply to reduce the pathogen population down to a manageable level, a level that the host's own immune system can then handle and clear out.
Which would be a huge challenge for anyone who is immunocompromised.
A very serious challenge, yes. Their immune system might not be able to clear even that reduced number of invaders.
And age plays a huge role here. Let's look at the lifespan considerations in box 8.1 for children.
There's a lot of controversy that the habitual use of antibiotics for, say, possible viral ear infections is a massive contributor to early resistance, and you have to monitor them very closely for GI and neurological effects.
And for older adults.
The signs of infection can be subtle. They can be atypical, so that culture and sensitivity testing is even more important. They're also highly vulnerable to toxicity because of decreased liver and kidney function.
Meaning, those organ-toxic drugs, which are most of them, have to be used with extreme caution.
Extreme caution. Monitoring nutrition and hydration is key.
Now, one strategy to handle the toughest infections, and this is critical to delay the emergence of resistant strains, is combination therapy.
Yes, for something like tuberculosis or severe malaria, you use multiple drugs at once.
Why?
It lets you use smaller doses of each one, which can mean fewer adverse effects. You can also get a synergistic effect where they're more powerful together, but the main driver is delaying resistance.
So let's talk about those unavoidable adverse reactions.
Since no drug is truly selectively toxic, the very properties that kill the pathogen are going to affect host cells.
So what are the most common targets?
Three main organ systems. First, kidney damage or renal toxicity. The kidneys filter these drugs, so they're incredibly vulnerable. We see this a lot with drugs like gentamicin.
And what's the key to managing that?
Close monitoring of kidney function and making sure the patient is really well hydrated to prevent the drug from accumulating.
Okay. Second is GI toxicity.
Right, and this can range from simple nausea and diarrhea to something much more severe. A drug like meropenem, for example, which inhibits cell wall synthesis, is associated with potentially fatal pseudomembranous colitis.
Which is exactly why it's reserved for only specific sensitive infections.
Exactly, when less toxic options have failed.
And the third system.
Neurotoxicity. Damage to nerve tissue. The aminoglycosides, like gentamicin again, can accumulate in the eighth cranial nerve.
Causing dizziness, vertigo, and permanent hearing loss. Ototoxicity.
Yes. And another example is polymyxin B. It alters cell membranes and can cause neurotoxicity that shows up as facial flushing, dizziness, and paresthesias, that pins and needles feeling.
Then on the immune side, we have to worry about hypersensitivity reactions.
The true allergic responses, yes. And it's so important when taking a patient's history to figure out if their reported allergy was a real antibody reaction or just a known side effect like nausea.
And you also have to watch for cross-sensitivity, right? Like between penicillins and cephalosporins.
You do.
And finally, the last big danger, superinfections.
This happens when the antibiotic wipes out the body's beneficial normal flora. That creates an opening for opportunistic pathogens to invade and thrive.
The classic examples being
Oral or vaginal yeast infections, and the really serious one, Clostridium difficile infection, or C. diff, which is strongly associated with antibiotic use. Monitoring for new signs like persistent diarrhea is absolutely crucial.
That was a tremendous deep dive. We've covered selective toxicity, the spectrum of activity, the 5 mechanisms of cell attack, the huge danger of resistance, and the critical adverse effects on the renal, GI, and nervous systems.
And if you connect it all to the bigger picture, the entire strategy of modern anti-infective therapy just hinges on preventing resistance.
It's a race.
It's a race, and winning requires appropriate drug selection through culture and sensitivity, correct dosing, and strict patient adherence. The provider's role in monitoring for toxicity and superinfection is paramount because, well, like we said at the start, that perfect magic bullet is still just an ideal. It's not a reality.
Absolutely essential knowledge. Thank you for joining us for this deep dive.
My pleasure.
And now, here is a final provocative thought for you to mull over. Considering the growing threat of resistant strains, how might regulatory bodies or healthcare systems further restrict the use of powerful, new, broad-spectrum anti-infectives to preserve their effectiveness for future public health crises? We'll see you next time.